Good evening. Thank you for coming tonight. I'm on the faculty at Stanford, and I've been working with prostate cancer patients for the last 35 years. It's a particularly important aspect of my life is that my dad died of prostate cancer, and I've got two brothers with prostate cancer. So as I tell my patients as we go through this, that I'm always thinking that my turn is next. And so I take very special care of my patients that have prostate cancer. I've been giving this kind of talk now for the last 25 years. What I'm going to be doing here today is giving you an overview of where the major changes are taking place in the detection and treatment of prostate cancer. In the last couple of years, it's been pretty amazing, the work that's been done and the breakthroughs that we've seen. I want to start here with an incidence chart here. This is the incidence of different cancers in the United States by year between 1975 and 2016. Now, the top curve is the prostate curve. You can see the other curves are all relatively straightforward, but prostate has these peaks and valleys because of the introduction of PSA screening and the removal of PSA screening at some particular point in time. So that when you look at the real peak there, that was in the late 1980s when PSA first became available. When PSA became available, all of a sudden there was this massive upsurge in the patients, numbers of patients that were diagnosed that were being found just because of this blood test. It quickly came back down because they flushed out the system of these people that wouldn't necessarily have been found if it wasn't for PSA. Where it really starts to plunge down in incidence is it correlates with the time that the United States Preventive Services Task Force made what I consider to be a rather erroneous recommendation that PSA screening be stopped. And when they stopped doing that, the incidence of it appeared to drop down basically because in many cases we were no longer looking. But overall in the United States, it's expected that 174,000 patients or people will be diagnosed with prostate cancer this year. And in California, 24,550 will be diagnosed with prostate cancer. It's the #1 non-skin cancer diagnosis in males in the United States. Now, prostate cancer it covers a wide variety, and that's what we're going to be talking today about the variety of this here. This is an important aspect that shows you what people are really at risk for dying of the disease. The first group of curves that you see, or graphs that you see there, is for patients that have localized disease. By 5 years, people that have localized disease, virtually no one has died. Regional means that these patients may have spread to their lymph nodes. Again, at 5 years, because of the way we treat them, the chance of dying is very, very small from the prostate cancer. They may die of something else, but their chance of dying of the prostate cancer, if they're appropriately treated, is extremely small. However, in patients that show up with distant disease, cancer that's in the bones or in the lungs, those patients have a 5-year survival rate of only about 30%. So they make up a small portion of these patients, but those patients have what we need to consider very high-risk disease and where we need to improve our treatments for them. At presentation, about 78 to 80% of patients present with localized disease, another 10% present with cancer that's in the lymph nodes, and only about 5 to 8% of patients present with metastatic disease at the outset. So you see that even though the numbers of diagnoses are high, the number of patients that have truly deadly disease is very, very low. This curve here is dealing with the death rates for various cancers in the United States, and it goes up to 2016. It stops at 2016. This just came out last month, 2016, because the data for the years 2017 through 19 is still being accumulated. But this curve right here is the prostate curve. You'll see that back up in about the year 1990, it reached its peak death rate from prostate cancer, and every year after that, it was declining. But when we stopped screening for prostate cancer, something changed. And what we're seeing here is the beginning of the rise. So it's plateaued, and most of us are experiencing an increased number of patients that show up with metastatic disease, meaning cancer that is spread, because we stopped screening early. So there's a lot of political discussions, a lot of reasons why they stopped screening early, but we will see, this is not only my prediction, but the prediction of many people, that this curve is going to start eking up again. And the reason is that patients that might have been picked up through screening are no longer being picked up because many of the primary care physicians have stopped telling them to get PSA screening. So our message to people is that Screening is still valuable because screening doesn't necessarily mean treatment. But if you don't look, you're not going to find it, and more patients are going to show up with cancer after it's already spread and become more dangerous. Now, when patients come in, they come in at all different levels of risk. And in the last 15 years, we've gotten better and better and better at breaking people down into risk groups based on a number of factors. Locally, some of the factors that we've been using for years are the PSA, both in terms of its absolute level and its rate of rise. As an example, the highest PSA I've ever seen in a patient was 17,000. So PSA has no upper limit at all. But the rate of rise of PSA is a well-known factor that can determine how dangerous a person's cancer is. The local stage of the prostate cancer, based on the digital rectal examination or what we see on MRIs and ultrasounds, is important. The volume of disease, which is measured by how much disease we can actually see on the scans, or when biopsies are done, how many of the biopsies are actually involved. And this thing called the Gleason score, which is a pretty simple scoring system that describes how bad the cancer looks under the microscope. Those are the base factors, but we're getting better now in this whole class of genomic tests. Genomic tests, the three big ones that are available right now, are called the Decipher test, the Oncotype DX, and the Prolaris, but there's more in development. These are tests that look at an array of genetic mutations that may or may not be present in each person's individual biopsies. These tests were based on patients that had surgery where the prostate was removed. They looked at the tissue of the entire prostate, they looked at the cancer cells, and determined which of these mutations were present. And they then followed the patients after surgery to see who had cancer spread. And what they identified was that some patients would have this series of mutations that were associated with a higher risk that their cancer would come back after surgery. And they were given a score. And each one of these has different scoring systems. But the simplest way to think of it is that if a person has a high genomic score after surgery, it predicts that those patients are at greater risk for the cancer coming back unless they get additional treatment. We are now using that after the biopsy only rather than just using it in prostate cancer patients, and I'll show you how we integrate that in a little bit. Other factors that determine the risk level is whether there's any evidence of metastatic deposits or sites outside of the prostate, like in the lymph nodes or in the bones. And another major important factor that determines the risk level for patients is whether they've had prior treatment. This categorizes patients into two major categories. Initially, hormone sensitive means that those cancers are responsive to treatments that eliminate or reduce testosterone. Later in the course of a disease, though, some patients become resistant, meaning it doesn't really matter what happens with the testosterone, the cancer will continue to grow, and they have a much more dangerous situation. So we use these risk factors then to break people into groups. Now, the majority of patients that walk through the door these days, and this is why the USPS task force recommended stopping doing screening, was because they have low to very low risk. Low to very low risk means that the chance of them spreading is extremely low, their risk of dying is extremely low, and many of these patients do not need treatment. Back in the year like 2010, before the USPS came out with their recommendation, everybody that got biopsied was getting treatment. And we treated far, far too many people because we didn't identify patients that really had such minor disease that they didn't need to get treated. If you do autopsies on men that die in their 80s, you will find some degree of prostate cancer in more than 50% of those patients. So those patients died of a disease, with a disease that was never going to bother them, and yet we were picking things up at biopsies, so we need to not immediately react to that requires treatment. That's hard from a patient's perspective, though, because if you're told you have cancer, you want to do something about it. So the options for patients that have very low risk are low to very low risk. I've laid out here on the side. But these are patients that show up with a PSA less than 10, a Gleason score of 6 or less, small volume disease, meaning just a couple of biopsies that show a little bit of cancer in them. And their clinical stage is either we can't feel it or we can just feel a small lump. Also, in some of these patients, anything I have highlighted in red is where we're making major trend movements right now, the low genomic score. So if a patient comes in and has a low genomic score and all these other things are there, we can say, we can do active surveillance in you. And that's a growing field. And I would say that about at least half of the men that show up in this category could be taken care of with active surveillance. Active surveillance doesn't mean that we're ignoring it. It means we're following it. We're going to keep on checking the PSA. We're going to repeat biopsies in the future, but we can avoid any kind of serious treatment that may lead to incontinence or loss of sexual function because they don't need it at this point. And very likely they will die of something else, with this never becoming a problem. Now, when you have patients of this group, active surveillance should be considered in every single patient here. Prostate cancer, though, is a profitable business. People make money off of people with prostate cancer. So you have to be careful if you've gotten diagnosed that you're not going to a place where they're going to say, oh, we're going to treat you because it's better to be safe on that side rather than sorry, because you may not need treatment. I would say that at some point we're going to find that patients that have Gleason 6 disease or less, that we stop calling it cancer, that we call it reactive change rather than cancer. But if a person does require treatment, or if a person really wants treatment after they've had this diagnosis, there are a wider range of options for them. There's radical prostatectomy. There's multiple forms of radiation. That can be done as what we call monotherapy. Brachytherapy is the internal placement of radioactive seeds in the prostate. That's another very acceptable way to treat this. Patients can be treated with external radiation using highly focused beams of radiation. SRS is one that's been gaining popularity in the last couple of years, where you're using radiation, but instead of treating over a 5 or 9 week course of treatment, you treat it in a 5-day course of treatment. So 5 individual doses in a week and you're done with the treatment. Proton therapy is available in a number of places in the United States, which is another form of beam therapy that's aimed at the prostate. Some of the newer things that we're looking at, though, is some patients may require treatment to less than the entire prostate. So HIFU is high-intensity focused ultrasound. If a person has minimal disease on MR scan on biopsies, and the biopsies correlate exactly with the MR scan, then we can consider treating with partial treatment to the prostate, where we use highly focused ultrasound to kill that portion of the prostate, rather than treating the whole prostate. That should be done in a carefully selected environment, though, because if patients have multiple areas of disease in the prostate, you're not a real good candidate for that. Risk reduction procedures that we're making advancement with have to do with radiation. That the prostate is located right next to the rectum and just below the bladder. And so when you give radiation, you run the risk of causing some injury to the rectum or to the bladder. So we have devised different techniques now of separating the rectum from the bladder by placement of some gel there called hydrogel. That's one way of doing it, so that you increase the safety margin. Another way is by being able to focus exactly where the prostate is second by second as you're getting treatment with the placement of beacons inside the prostate. We have these radio transmitter beacons called Calypso beacons that we can easily put in the prostate. The patient goes on his machine for his daily treatment, and we can see it move in any dimension, and we can alter the beam to match that motion. So these are risk reduction procedures that increase the safety margin for radiation. But these make up the vast majority of patients. I'm going to move on to the next group. Now, these next groups are smaller and smaller volumes of people. These are the intermediate risk patients, and I break them into low and high intermediate. Low intermediate risk patients are patients that have stage T1C or 2B, meaning that either we can't feel it or we just feel a small lump, but their PSA is in the 10 to 20 range, or their Gleason score is 3+4. Again, these patients may have minimal volume and they may have a low genomic score. If they fit into this category right here, we are now doing active surveillance on a lot of those patients, especially through the VA hospital. We've got lots of patients who are following very safely there. You're still eligible for surgery, still eligible for all those forms of radiation with the risk reduction procedures, and we're considering HIFU for these patients as well. So these patients are not tremendously different than the low-risk patients that you saw beforehand. But when things get a little bit more hairy, we have to start upping the ante in terms of the treatment we're going to use. So high intermediate risk patients are, again, patients that have that either minimally palpable or non-palpable disease, but their Gleason score has switched. It's gone to a 4+3. That means that more of the cells that we see in there are a high grade and they're more dangerous. We also may find that their PSA is still in the 10 to 20 range, and these patients may have a high genomic score. So in these particular cases, unless we think they're going to die within 2 to 3 years, we should not be doing active surveillance. We should be taking an aggressive stance toward these patients. Again, surgery is an option. The patient may be an option for radiation, and in some of these cases now, we start looking at hormone therapy as an added adjunct to help improve the chance of beating the cancer. Generally, this is short-term hormone therapy. It's based on the idea that by temporarily taking away testosterone, we change the nature of the cancer cells so that when the radiation is delivered, it has a higher chance of killing those cancer cells. So not everybody needs the androgen blockade or the hormone therapy, but many of these patients may benefit from it. There's a large number of studies that are aimed at trying to identify who exactly needs it, but you have to be careful in who you use it because of the potential risks to the overall health of the patient. These patients, rather than having monotherapy or just one particular type of treatment, we will often use a combination. So these patients are the first group of patients that we may do external radiation in combination with the internal radiation, or that we may do the external radiation with an external boost of those very high dose per fractions to deliver a higher dose in there. The message here is that the greater the volume of disease, the greater the grade of the disease, if you're going to use radiation, the greater the dose of radiation you need to use. We have a number of good phase 3 studies right now that show that by upping the dose, you have a better chance of beating the cancer in these particular cases. Now, some of those patients will have gone through surgery. And if they've gone through surgery, not everybody needs radiation. Most patients do not need it, but we've identified a number of patients that do need treatment. Radiation treatment and hormonal treatment after surgery is broken into two groups. It's broken into what's called adjuvant and those that are called salvage. Those words you're going to see a lot in your readings here. Adjuvant means that the person's had surgery, the PSA has gone to 0, but they identified some factors at the time of the surgery that indicated that radiation may be helpful. So adjuvant means no PSA. Salvage, on the other hand, means you've gone through the surgery, you may or may not have had some bad factors, but your PSA is still measurable. Your PSA should not be measurable after surgery. So 2 or 3 major reports just came out within the last month that indicated that we should not be giving radiation necessarily in the adjuvant setting. And up until these studies came out, we were offering it very often. Now there's a number of large-scale studies that show that it is safe to hold off on the radiation until there's a sign that the cancer has come back. And that sign is usually first a rising PSA. So you may go through surgery and we may find that there were positive nodes, for instance, or there was a positive margin, or that the genomic score was high. All of those things predict that the patient's cancer has a higher risk of coming back. But if the PSA is undetectable, it is safe in those patients to continue watching. What you don't want to do is go through the surgery and then forget about it and never check the PSAs. Because by the time the cancer becomes obvious, it's going to be a much more dangerous situation for you. So there are several large-scale trials that have looked at who should benefit and how we should best treat them. This trial was reported at our meetings last year, but has not yet been published. It looked at patients that had a rising PSA after surgery. When a rising PSA is present, we don't know where the cancer is. We just know that the PSA is going up. This gives us an indication of how to best treat those patients. And depending on where the PSA is and what findings were seen at the site of surgery, we may or may not recommend androgen blockade. And we may treat with just radiation at the prostate bed or radiation at the pelvic lymph nodes as well. So this was a major step forward for us to help a patient understand how we need to treat them after surgery. These trials, I'm going to get to in a little bit. I'm not going to mention them too much right now, but these have changed the nature of all treatment for prostate cancer over the last couple of years. And I'll get into them in a second. Another major area where we're seeing great breakthroughs is the detection of prostate cancer at a very, very, very small level. So a guy goes for surgery. His PSA after surgery is like 0.05. When we scan, we can't find cancer anywhere. So we know there's cancer, we just don't know where it is. If you wait until the PSA gets up to a level of 1, we often find it on the scans. But If you wait till it gets up to 1, the chance of cure drops down. So we've been looking at ways to identify where the cancer is when the PSA is very low. And these are all new PET scans, some of which have got FDA approval, many of which do not, but they're all in experimental testing throughout most academic centers. So at Stanford right now, the C11 acetate study and the Acumen scans are both FDA approved, and they're sensitive, but then we have 3 new ones that are more sensitive than that: the PMSA, the Bombesin scan, and the DCF-PYL scan. So in this particular picture here, this patient was a patient that had a PMSA scan. You can see the tiny little area here that's lighting up. That's a lymph node that would not show up on MR scan, bone scan, CT scan, and wouldn't show up on the earlier Acumen scan, but it does show up on the PMSA scan. And so that gives me a target when it's time to give radiation, that I know there's cancer there, and I can get a higher dose of radiation into that region. So the work that's being done in PET scanning is really exciting. The step beyond that, I'm going to mention once at the end, is that taking this same marker that can find this cancer at a minimal stage, we're going to weaponize it. We're going to hook it up with a radioactive material so that when we give it to the patient, it will go there and it'll deliver a radioactive source directly to the cancer cells and kill those cancer cells. That's called radioligand therapy. It's still not available in this country outside of research studies, but it's going to be a game changer, because if it works in this minimal disease, we may find that we can use it up front for patients that have cancer and eliminate external radiation, eliminate surgery. So in the next 5 to 10 years, we may see some tremendous changes because of what's taking place in nuclear medicine right now. Now, we step up the next one. This is the patients that have truly high-risk disease. These are the patients that when they come in to see me, I say, you should have started your treatment yesterday because the cancer is not waiting. These are patients that have a PSA greater than 20. They have a Gleason score of 8, 9, or 10. They have T3 disease, which feels like a big rock breaking outside of the prostate, or T4 disease breaking into the bladder and rectum. But they're node negative still, and their scans don't show any evidence of disease. So these patients, without treatment, within 5 years, their cancer will be everywhere. So these patients need to be treated. They should not be messing around. Now, if I've got a patient that's got multiple other medical problems, and it looks like they're not going to live more than a year or 2, I may not do anything for them. But if they're going to be living more than 2 years, I think that they should be treated for this. This requires one more step up in terms of intensity of therapy. These are patients that go for surgery and very often need radiation and hormone therapy afterwards. If they're going to get a combination therapy, they'll get external radiation, the intensity modulated radiation therapy, and the internal radiation brachytherapy, but then they're treated with extended androgen blockade. So they're put on hormone therapy for about 1.5 years, possibly longer. This group of patients is also the area where we are looking at adding in new agents. So the standard for years has been either surgery, radiation plus hormone therapy. But patients that had cancer that came back afterwards, we've identified 5 or 6 different new drugs that improve the outcome later on. We're moving them up into the circuit so that patients with high risk may get these trial agents earlier. And all of these patients, this past year, the National Cancer Care Network came out with a recommendation. All of these patients should undergo genetic counseling for the family, because if they have these, they have an increased risk that they have a genetic abnormality like BRCA1, BRCA2, or 5 or 6 different ones we've identified. That's important to know for the family, so the family can know what kind of screening they need to go through as well. So that's our current recommendation, is that any patient in this group consider genetic counseling. At the lower risk groups, there's really not a reason to do that unless they have a very, very strong family history. But just the nature of the cancer in this case is associated with a higher risk of a genetic problem. Very high risk, though, are patients that have lymph nodes seen on scans, or they have bone metastases, or they have a PSA greater than 50. Also, patients that have castration-resistant disease. So these are patients that have previously been treated with, say, surgery with radiation, and they were doing fine. Their cancer came back. They were put on hormone therapy for a period of time, but then the cancer started breaking through the hormone therapy. So in these particular cases, we talk about patients that don't have cancer someplace else in the body, but they've failed surgery, they've failed radiation, and they're failing hormone therapy, and they've become castration resistant. Then the next step beyond that is those patients that have castration resistant disease that now have bone metastases. And these are the patients with the shortest life expectancy. These are the ones that need the most help right away. We break them down into two groups too. We're really good at breaking people into groups here of low volume versus high volume. Low volume means that they may have just 5 or less metastatic sites in the body. High volume means more than that. And where those numbers came from were studies that had to pick a number, and they chose 5 as one that they thought was reasonable to start looking at differences. And these things do have an impact on whether or not some of the treatments that are available may be better or worse. So for these groups of patients right here, all of them are put on androgen blockade. And one of the important things about this is that when you have this bad cancer that's spread to other parts of the body, say a person has 10 spots in the body, 9 of the spots in the body may still be suppressed by the hormone therapy, but 1 spot is causing the PSA to go up because it's no longer responding to the hormone therapy. So we start adding in all these different agents. And these agents that are all listed in red right here have come up in the last 5 years to 7 years in trials. Each one of them has improved the duration of survival. It's improved the overall survival for patients. And we're trying to move them up earlier into the course of treatment. So there's certain types of chemotherapy. There's androgen receptor blockers like enzalutamide and apalutamide. There's abiraterone. Provenge is the first vaccine that was developed for it. Xofigo is a radioactive substance that we use now for patients with bony metastases. Stereotactic radiation is being looked at. But some of the more exciting things that are coming next are we're finally looking at immunotherapy for this, like we've used in other diseases. So as a brief point about immunotherapy is immunotherapy has changed the picture for metastatic melanoma. We have patients that, like Jimmy Carter, he's turning 95 this week. Jimmy Carter had melanoma in his brain several years ago. Well, with the use of immunotherapy, his disease is under control. Immunotherapy doesn't work in every disease. It works really well in many patients with bladder cancer, with kidney cancer, with some lung cancers. It's not been successful yet in prostate cancer, but it may be just that we haven't found the right combination of medications for it. So we're working on that through studies at all academic centers, including Stanford. And the radioligand therapy that I mentioned is going to open up within the next year at Stanford as well. Here's some of the examples of how these things are working. So for newly diagnosed, high-risk, hormone-sensitive cancer, means that it's not castration-resistant, the STAMPEDE trial, I'm going to show you a series of curves here. These curves, the thing that's important about them is that they're showing a difference in survival, the number of people alive at time, depending on whether they were treated with what's called the standard of care, which was hormone therapy, just plain and simple hormone therapy, or hormone therapy plus another agent. So in this particular case, this was part of the STAMPEDE trial. These were patients who were treated with hormone therapy, or we added in abiraterone. And this was a major step forward in terms of the cure rate for patients. So when you get out to 5-6 years, more people are alive because of the addition of this drug. And we've moved this up earlier into the course of treatment. The STAMPEDE trial was a fascinating trial that was set up in Great Britain, and it started in about the year 2004. It was a study that looked at standard of care treatment for these high-risk patients, and it added in 5 or 6 different approaches in the study, and each one had its own individual randomization. And so in a short period of time, instead of doing one after another, they were able to identify a number of different drugs that improved the outcome for people. Abiraterone is one of the drugs here.
Upstairs is clear.
In another study looking at patients with metastatic hormone-sensitive disease, there was a trial called the Latitude study. This also showed an improvement with abiraterone. So we know that abiraterone makes a big difference for patients that have high-risk disease. The Charted study looked at a type of chemotherapy. This was called docetaxel, and this also showed an improvement in the overall survival in patients with all patients, but especially notable in patients that had high volume disease. So the abiraterone that I showed you beforehand was given for 2 years for patients. This was given in a matter of 3 or 4 months. But the improvement in survival was actually the same whether patients got docetaxel or abiraterone, but they just have never been compared side by side. One study was run where they gave abiraterone and docetaxel, and it didn't make any difference. So you didn't need both. One or the other is sufficient. The big question for us is which is the right one to use. This was another trial called the Titan trial, again for hormone-sensitive cancer. This used apalutamide, and this also showed an improvement in survival. It's a pill. It's an extremely expensive pill, but it's a pill that also improved the outcome for these patients. And then there was the Incidence study, which looked at patients that had the same disease, and it treated them with enzalutamide. So we basically show that docetaxel, enzalutamide, apalutamide, and abiraterone all improved the outcome for patients, kept more patients alive a longer period of time. And not only that, but on a secondary level, it showed that there was less development of new metastases, less development of fractures in bones, less need to change therapies. So these things have made a big change in terms of how we take care of our high-risk patients. We've used it for years in the past with patients that had hormone refractory disease or castration disease. Now we're using the hormone-sensitive disease. So when a person walks in the door, we want to know exactly how much disease they have and what kind of treatment options are maybe available at that point in time. So these are all game changers. And about 15 years ago, when I would see a patient that had cancer in his bones, I would tell him that the average time to death after presentation of cancer in the bones was about 2 years. Now, if a person comes in, they've got cancer in the bones, it is very common for me to see that patient live for 10 years. And more than half of them are alive beyond 5 years. Now, those have been little baby steps we take, but they've added up. The challenges for us are to determine which order to give them in. So all of the studies that are out there right now are trying to identify if you came in with this high-risk disease, you're going to get hormone therapy, but should I give you apalutamide? Should I give you enzalutamide? Should I give you chemotherapy? And the decisions are usually made by physicians that are aware of what your medical problems are, what the potential toxicity of each one of them are, what the costs of some of them are. So for instance, if you're caught in the donut hole and you're going to try and get enzalutamide or apalutamide, which is going to cost thousands and thousands and thousands of dollars because it's not covered completely by your insurance, it may make more sense to go with the docetaxel, which you can complete in 6 months and have it completely covered by your insurance. So there's these aspects of the decision that get into the financial level, but mostly they're tied into what your risks are from the individual drugs. So overall, where we're going, it's really an exciting time to be here. It's frustrating for me to see that rise in the death rate again, because that was a political mistake. That was a mistake, in my opinion. Not everybody believes it, but I believe that it was a decision made based on a lot of factors that we're trying to reverse now. But we're getting better and better at keeping people alive longer, but it still is better to identify the cancer early and watch it if it's low risk, treat it if it's high risk. So we're looking at better ways of determining who's a good candidate for active surveillance, whether it be through the genomic scores or looking at all these factors overall. We're looking at partial prostate therapy in highly, highly selected patients. We're looking at local interventions to ensure increased safety, like the hydrogel and the Calypso beacons. We now have improved imaging and identification for the loci of disease. Right now, those things are experimental, but I would say within several years, they're going to be moved up and they're going to be FDA approved. And if a person comes in before I start any treatment, I'll be able to get these scans and see if I can find cancer outside of the prostate. We're looking at the integration of new agents in earlier high-risk setting cases. We're looking at immunotherapy and radioligand therapy. But one thing I tell every one of my patients after their diagnosis is that a critical element is your change in your lifestyle. Once you've been diagnosed with prostate cancer, hopefully you're low risk, hopefully we'll get it cured or it'll never cause a problem, but you can never guarantee that. So you have to modify your life, because if a person's going to be put on hormone therapy in the future, it has tremendous impact on the quality of your life. Hormone therapy causes great weight gain, rises in blood pressure, rises in blood sugar, increasing risk of cardiac death. You age quicker. So if you've got the diagnosis, we should all do this, but if you've got the diagnosis, certainly you need to look at modifying your diet so you keep your weight under good control and your blood pressure under good control, and that you need to look at exercise. Exercise, especially cardio exercise, so that you can keep your weight off, you can keep your heart strong, and you can keep your bones strong going forward, because all of these therapies could have a negative impact on the strength of your bones and on the health of your heart. So my take-home message is for everybody that doesn't have cancer, that cares about their loved ones, is encourage screening, especially if there's a strong family history. If there's not a strong family history, I recommend that you get tested after the age of 50. Encourage them to gather information once they've got the diagnosis, and for the most part, you don't need to rush into a treatment. You need to become aware of it. You need to modify your life, and if you've got the diagnosis, you should be thinking 3 to 4 steps ahead. Not just thinking about what I'm going to do today, but what I'm going to do if it comes back, and in what order am I going to do things if it comes back. And I'm going to stop at that point.